Welcome to the ninth module for the Global DARE Foundation Patient Collaborator Training Series. My name is Mousumi Bose, and I will be your narrator throughout these training modules to help you become an active patient collaborator in ongoing and upcoming research for adult refsum disease. This module provides an overview of genetic testing and its role in diagnosing adult refsum disease. We will start by discussing the role and history of genetic testing, followed by different genetic testing approaches such as single gene sequencing, multiple gene sequencing, whole exome sequencing, and whole genome sequencing. We will then explore how these methods are used in the diagnosis of adult refsum disease, along with their broader implications for research and inpatient care. Finally, this module will conclude with a case study to help apply these concepts in a real-world context. So genetic testing plays a critical role in healthcare, especially for rare diseases, since 80% of all rare diseases have a genetic cause. And because treatment options in rare diseases are often limited, getting an accurate diagnosis through genetic testing can significantly improve patient outcomes. Early diagnosis allows for earlier intervention, which can slow disease progression or improve quality of life. It also helps guide more targeted and personalized therapies rather than using a simple trial and error approach. In addition, genetic testing can prevent unnecessary procedures or treatments, and it allows healthcare providers to monitor patients more effectively based on their specific condition. So before we get into what are the current approaches to genetic testing, let's provide a little bit of a background. So the history of genetic testing reflects major scientific breakthroughs over the past century. When we're talking about our broad understanding of genetics, that timeline can go back as early as the mid 1800s. But our timeline with genetic testing, we're going to start in the early 1900s when it was first observed that a condition called alkaptonuria, which is a metabolic disorder of amino acid metabolism, followed a specific inheritance pattern in families, making it one of the earliest diseases linked to a genetic cause. 1961 saw the development of the first newborn screening test for phenylketonuria, or PKU, marking a major step toward early detection of genetic disorders. By 1983, researchers identified a genetic marker for Huntington's disease on a specific chromosome, chromosome 4, advancing our ability to locate disease-related genes on DNA. In 1986, positional cloning was introduced, allowing scientists to identify genes without knowing the protein that genes provided the instructions for. And this was especially important for studying inherited conditions like muscular dystrophy. The field expanded significantly in 1990 with the launch of the Human Genome Project, a 15-year effort that successfully mapped all 3.2 billion base pairs of human DNA. And this is really what allowed for single gene sequencing, which began moving into clinical practice around the early to mid 1990s. And this type of sequencing testing enabled clinical testing for single gene disorders, as well as paved the way for the development of multi-gene panels for diagnostic testing. Finally, in 2005, next generation sequencing revolutionized genetic testing by enabling rapid, large scale, and broader DNA analyses at much lower cost as well as time. Together, these milestones laid the foundation for modern genetic testing and precision medicine. So now that we have a little bit of a background on genetic testing, let's talk a little bit about the types of genetic testing that are being used in current clinical and research practice. And I'm going to start with the most straightforward, which is single gene testing. Single gene testing focuses on analyzing one specific gene at a time. So when we're talking about genes and DNA, I like to use this analogy of our DNA, which is located within the nucleus of any given cell in our body. This DNA being like the instruction manual for all of the proteins that are made within the cell that DNA is located. A gene is a little stretch, a little chunk of DNA that contains the instructions for one specific protein that's made within that cell. So with single gene testing, there needs to be some kind of suspicion that there is an error in the building of a specific protein that is causing the symptoms of a particular condition, and this error in the building of that protein is caused by an error, often referred to as a variant, in the specific gene, which is the instructions for that protein. So this single gene testing approach is typically based on clear symptoms associated with that error or a known family history of that disease or condition. So this type of genetic testing will find the location of where that specific gene is across the entirety of the DNA for that cell, sequence, or in other words, screen it for those errors, otherwise known as variants. And then that information, if that variant is there, or if there's an error there, that information can tell us if the symptoms that a patient is experiencing is due to that variant in that gene or not. Single gene testing can be used to help confirm a diagnosis, determine whether or not somebody is a carrier for a disease, or assess the risk associated with a known disease-causing variant within that gene. However, there are some limitations to using single gene testing. First, this approach only examines one gene, and this means that it may miss other potential genetic causes if multiple genes could be involved in this condition or disease. Additionally, there needs to be very distinct clinical findings that can be recognized by someone with expertise with that specific genetic condition to even prompt this kind of testing. So without that level of expertise, using the single gene approach may result in misdiagnosis or a delayed diagnosis. Multiple gene sequencing analyzes a group of genes that are related to a specific clinical symptom or a biochemical marker, all from one single sample. This method is more time efficient and cost effective than testing for one gene at a time. This approach is especially helpful when a patient's symptoms could be linked to several possible conditions or diseases and therefore several possible genes. However, while multiple gene sequencing can narrow down the possibilities, it does not always provide a definitive diagnosis. And in those cases, broader approaches such as whole exome sequencing or whole genome sequencing might be necessary. So let's quickly recap where this type of targeted genetic testing fits into diagnosing a rare disease. When we are using single gene testing, we are typically looking at a very specific disorder. This is most appropriate when there is a known family history or when a patient presents with clear classic symptoms that strongly point that strongly identifies variants of one specific gene that is causing the symptoms of this condition or disease. On the other hand, multiple gene panels are useful when we suspect a genetic condition, but the picture is a little bit more complex. In these cases, the patients may still have clear symptoms, but there may be multiple possible genes that could be responsible for these symptoms, so we sequence for several at once. In both of these approaches, these rely on having a relatively strong clinical clue about what we're looking for. But what happens when we don't have that level of clarity? So this is when we start to consider more broader approaches like whole exome sequencing and whole genome sequencing, which we will dive into next. So whole exome and whole genome sequencing are typically used when a diagnosis is unclear or symptoms are complex. Unlike single gene sequencing or multi-gene panel testing, these approaches allow us to screen more broadly across the entirety of the genome, which in other words is all of the DNA within a cell. Whole exome sequencing focuses on the screening of specific regions of genes, which we call the coding region, where most disease-causing variants occur. While whole genome sequencing looks at the entirety of the DNA sequence, and this approach, the whole genome sequencing, often follows whole exome sequencing that has resulted in no clear answers. Both of these methods are especially useful when patients have unexplained symptoms or when previous genetic tests have not provided a definitive diagnosis. So let's talk about these broader types of genetic testing. So I'm going to try to explain the major differences between whole exome and whole genome sequencing using that analogy that I used earlier of your DNA for any given cell being like this huge instruction manual. So in an instruction manual, we know that we've got the instructions to make the thing that we're trying to make. In this case, it's a protein or a number of proteins. It's also important to recognize that there's more to that instruction manual than just the specific instructions. Oftentimes in these instruction manuals, we see chapter designations, an index or a glossary of terms, and sometimes there are tips or hints that are included in the margins intended to aid in the instructions themselves. The exome, which is made up of exons, these are the specific instructions in that manual. So within a given gene, which remember contains the instructions for one protein, the exons are the part of that gene that are the specific instructions to make that protein. We call all the exons, collectively called the exome, as the coding region of a gene, because that is the part of the gene that is actually copied and sent out to the assembly line to actually make the protein, and this occurs outside of the nucleus. Whole exome sequencing focuses on screening or sequencing just those sections that actually give those specific instructions for making that protein. These sections, it should be noted that these sections make up only actually a small portion of your DNA. But as I said before, they are where many known disease-causing variants or errors happen. The other parts of the manual, that is the index or the glossary or the helpful hints that aren't necessarily instructions but help with the instructions, they're not part of the exome. Okay, they're not the instructions. And these parts in the genes are referred to generally as the introns. And these are stretches of DNA within a gene that may be useful to the instructions, but aren't actually the instructions themselves. So this information is not copied over to the machinery that makes the protein. So we refer to this as the non-coding region. So whole genome sequencing screens through everything, the entire manual, including both the instructions, that's the exome, made up of those exons, as well as the other parts which may be useful but are not actually part of the actual instructions themselves. We call these parts the introns. So to summarize, exome is referring to the specific instructions in the manual. The genome is referring to the entirety of the manual. When we're doing whole exome sequencing, this broad screening is often faster and more focused than whole genome sequencing, because again, whole genome sequencing is all of the DNA, the entirety of that manual. This tends to be much more comprehensive, and it can find things that we might otherwise miss. And choosing between whole exome sequencing and whole genome sequencing really depends on how much information we need to answer um, the specific question at hand. So this image is one that I've seen often to use another analogy to help explain the differences between whole genome and whole exome sequencing. So this entire apple here is meant to represent the whole genome, which includes all of a person's DNA. The small slice that you see next to it represents the exome, which is only about 1 to 2% of the entirety of the genome and contains the parts of the DNA that actually provide the direct instructions or the code for specific proteins. Whole exome sequencing focuses on this smaller, more important portion, while whole genome sequencing looks at everything. So once again, these methods are especially useful when a diagnosis is unclear or more detailed genetic information is necessary. However, a key limitation is that both whole exome and whole genome sequencing are both more expensive than single gene or multiple gene sequencing. So putting this all together, this algorithm outlines a stepwise approach to genetic testing based on a patient's clinical presentation or symptoms. We begin with a patient who shows signs suggestive of a genetic condition. This could be, this could include distinct clinical features, um, a relevant family history, or perhaps abnormal lab findings. If the presentation, meaning that those clinical symptoms, point towards a single gene disorder, then that is well known and well defined by these specific symptoms, then single gene sequencing is typically the first step. However, if multiple genes and multiple conditions could be involved based on those clinical symptoms, a multiple gene panel may be more appropriate, as it allows for a more broader but still targeted analysis of particular genes that may be related to those symptoms. For patients with complex, non-specific symptoms such as, say, autism or intellectual disability, or when no specific gene panel is available, whole exome sequencing is recommended to evaluate these coding regions. These are the specific instructions across many genes. And finally, if exome sequencing is inconclusive or a more comprehensive analysis is required, a whole genome sequencing approach can be used to screen both the coding portions of the DNA within that cell or the non-coding regions, otherwise known as the introns. This algorithm helps clinicians or medical professionals choose the most efficient and most informative testing strategy while balancing cost, time, and overall diagnostic yield. So let's apply this diagnostic algorithm to the diagnosis of adult refsum disease. So just like that general algorithm showed, the diagnosis of adult refsum disease involves a combination of clinical observation, biochemical measurements, as well as genetic approaches. First, clinicians or medical professionals um, generally will identify key clinical features, which typically appear in between the ages of 10 and 20. And they're usually related to vision changes, which is generally from the retinitis pigmentosa that often occurs in adult refsum disease. But these clinical features may also include neurological symptoms or any other symptom involvement that is related to adult refsum disease. From there, we often pair these clinical signs with biochemical testing for altered levels of things like, say, phytanic acid, pristanic acid, and other related metabolites. And this can give us important clues about what pathways might be affected and in this condition and causing the specific symptoms at hand. And so at that point, we move into genetic testing. And that's the specific approach of genetic testing depends on how clear the picture is. If the symptoms are recognized by the medical professional as symptoms of adult refsum disease, and perhaps supported by biochemical testing, we might use single gene sequencing to look for adult refsum causing variants in the PHYH or the PEC7 genes, which are the two genes where variants occur, where adult refsum disease causing variants occur. If the medical professional conducting the diagnosis recognizes these vision issues and the associated retinitis pigmentosa, they may use not single gene testing, but a multi-gene testing panel. So for example, in retinitis pigmentosa, there are many genes that can lead to retinitis pigmentosa, including adult refsum disease. And this is where a panel of gene sequencing for specific disease-causing variants in different genes allows us to test all of those genes at once rather than one at a time. And when the diagnosis is still uncertain, or we want a more comprehensive look, we turn to whole exome or whole genome sequencing. So, how targeted or how broad we are approaching genetic testing in a specific situation really depends on how much we know at each step of that diagnostic process. And since we're talking about diagnosis of adult refsum disease, I think it's important to note that diagnosis plays a critical role in advancing research for adult refsum disease. Because adult refsum disease is so rare, every diagnosed patient that provides data that researchers rely on to better understand this disease um, is so valuable. There are still many unanswered questions, like why symptoms vary between individuals with adult refsum, why some patients progress faster than others, and how specific gene variants influence clinical presentation and symptoms. Having a confirmed genetic diagnosis allows researchers to identify patterns across patients, connect gene variants to symptoms, and better understand disease variability. So, in the context of diagnostic testing for all rare diseases, I think it is really important to at least talk briefly about newborn screening for inherited diseases and the policies around this kind of testing in the United States. These policies make it possible to potentially omit the need for certain types of evaluations or assessments that take place during diagnostic testing, and this may often result in a much shorter time to diagnosis. So the Recommended Uniform Screening Panel, or the RUSP, is a standardized list of diseases and conditions that all newborns in the United States are screened for at birth, as authorized by the Department of Health and Human Services. So, newborn screening typically includes a heel stick blood test, pulse oximetry to assess heart health, as well as a hearing screen. And the tests associated with the RUSP mainly look for biochemical markers, such as different metabolites that can indicate the presence of a certain condition or disease early in life. So historically, conditions could be added to the RUSP if there is strong evidence that early detection improves the health outcomes for this disease, for patients with this disease, and if a reliable screening method exists. But it should be known that at the time of this recording, the advisory committee responsible for nominating new diseases to the RUSP has been dissolved. So currently, there is no path to nominate new diseases and conditions to the RUSP, and that's what the little asterisk that you see there is meant to represent. But hopefully, that will change soon. So, newborn screening is an important public health tool used to detect serious conditions early in life, often before symptoms even appear. However, for adult refsum disease, traditional newborn screening is currently not feasible because phytanic acid, which is the key biomarker or metabolite for adult refsum disease, does not accumulate to detectable levels at birth because phytanic acid is found only in the diet and needs to accumulate over time to be detected in blood. So until there is another robust biomarker for adult refsum disease that is independent of diet, it's going to be difficult to test at birth with just biochemical testing, which is the common approach for all RUSP-aligned newborn screening. That said, I did want to also share that although most newborn screening testing is biochemical testing, testing for genetic material has been successfully incorporated into newborn screening for other conditions, such as severe combined immunodeficiency disorder, otherwise known as SCID or SCID. SCID is a rare genetic disorder in which infants are born with little to no functioning immune system, leaving them extremely vulnerable to life-threatening infections. The newborn screening process for SCID uses a DNA-based test, which looks for certain pieces of DNA within the blood sample. If these specific pieces of DNA are not detectable, then this suggests problems with T cell development. And T cells are very, very important cells in the immune system that are responsible for fighting viruses as well as cancer. So this suggestion that there's a problem with T cell development may be caused by SCID. Since the addition of this DNA-based assay to the RUSP in 2010, SCID screening has significantly reduced early life infections by enabling prompt diagnosis and treatment. And what's more, this DNA-based assay has helped identify over 14 other different genetic syndromes that are involved with immune system dysfunction. So this case study that I've linked um, with this module follows Ava, who is an infant that experienced severe persistent infections from an early age. Despite multiple doctor visits and treatments, her condition worsened, eventually leading to a hospitalization with severe complications and an initial misdiagnosis of leukemia. After seeking a second opinion, Ava was correctly diagnosed with a type of SCID disorder. And this rare and life-threatening condition, once again, is where the immune system does not function properly. Without early treatment, infants with any type of SCID often do not survive past their first year. Um, Ava underwent a life-saving hematopoietic stem cell transplant, followed by a long and challenging recovery that included complications like graft versus host disease. And after months of treatment and care, she was able to return home and is now a thriving child. Her story highlights the importance of an accurate and timely diagnosis, as well as the life-saving potential of advanced treatments, newborn screening, and genetic testing in rare diseases. And while this specific DNA-based assay that I was referring to earlier is very different from the standard genetic testing that uses sequencing methodologies, like I had described earlier, this newborn screening for SCID shows that population-wide DNA-based screening is indeed practical, scalable, and clinically impactful, which will hopefully pave the way for more broader use of genetic testing like the standard sequencing in newborn screening programs. So I want to circle back to talking about adult refsum disease and specifically the role that patient collaborators play in advancing research on adult refsum within the context of genetic testing as well as diagnosis. So by sharing their genetic information, such as their variants in either the PHYH gene or the PEC7 gene, along with their personal disease experiences, patient collaborators provide data that researchers cannot obtain anywhere else. This includes details like the time to diagnosis, symptom progression, response to treatments, and any misdiagnoses or delays in diagnosis or care. This information is incredibly valuable because what it does is it helps researchers connect genetic changes to real world symptoms, improve the understanding of how a disease develops over time, and support the development of robust biochemical markers, which can be extremely useful in the development of clinical trials. So to conclude, genetic testing plays a critical role in diagnosing rare diseases like adult refsum disease and is often essential for guiding patient care. It not only improves the chances of early and accurate diagnosis, but also opens the door for more targeted and effective treatments. We also saw that there are multiple types of genetic testing, ranging from single gene sequencing to whole genome sequencing, each with its own strengths depending on the specific clinical situation. Finally, while challenges still exist, especially in conditions like adult refsum, genetic testing continues to advance and may eventually expand into newborn screening, further improving early detection and outcomes. Looking ahead, our training series continues with several modules designed to deepen your understanding and engagement in rare disease research, specifically focusing on adult refsum. Coming up next, we will cover the current and emerging therapies for adult refsum disease. So I want to thank you for your time today. I encourage you to complete the survey linked to this module. I'm excited to continue guiding you through these upcoming modules. See you in the next video. For more information or if you have any questions, please contact the Global DARE Foundation.